Good morning. Good morning. My name is Jeff Brown, Executive Director at Oakland County Community Mental Health Authority. And I welcome all of you for the morning session of the two-session educational commitment on trauma-informed care. Oakland County Community Mental Health Authority's mission is to advance social equity, social justice, and improve the quality of life for those we serve. It's clear that the mission of Oakland County Community Mental Health Authority cannot be realized without excellence in its core provider agencies. And I want to, in this group, very rarely do I see everybody from all the agencies collected in one place. And so I want to begin by saying thank you for the service that you provide, the supports that you provide, the over 24,000 people that are Oakland County citizens that are served. And clearly without your excellence, it would not happen. Also, the staff of Oakland County Community Mental Health Authority also want to thank for the organization, the leadership, the direction and oversight, and to make sure that we are the partner, the state partner, that will be able to ensure that every citizen of Oakland County who needs service and supports is able to obtain them. Specifically for today, I want to start by just thanking the committee that has put this together. I want to recognize, and if you guys could stand, they're probably still working a little bit, but the committee that was involved in organizing this was Dawn Jones, Jen Hillier, Sue Felton. Victor, that applause is for you. And several folks have helped put this together as well. Cheryl Lois, Nicole Lawson, Matt Brinkman, Al Jeske, Anya Eliason, Carlton Atkins, Janice Short, Peter Mott, Teresa Ansett, and Becky Cook. Have to make sure all these other visitors are technical. I've been promised that I would do some housekeeping items also. For those of you who are needing at any time in the session, bathrooms are on both sides of the lobby. Coffee and snacks on both ends. For those who need continuing education certificates for CACs, social workers, all who are needing, sign in, sign out. There are papers at the out in the lobby. This presentation is going to be on the Oakland County Community Mental Health Authority website. And this presentation is required for everybody who is working under contract with Oakland County Community Mental Health Authority in one way or another. And this is the first of two sessions. I'm going to be leaving and coming back for the second session with about another group of this size. But when you guys are done, you're going to have to leave quickly. Have a logistic problem making sure that things get ready for the next group. So make sure everybody's done with their questions and all the comments, and then we'll move on to the next one. I don't need to tell anybody that we're in the midst of a healthcare revolution. And while systems of service delivery, service financing, and the number of people in need are increasing and being redefined as we're speaking, it is an absolute requirement that trauma-informed service delivery be a significant part of the dialogue and an intentional focus of our practice. Trauma has profound implications for mental health, addiction care, and trauma-informed behavioral health services and systems are at the epicenter for healing trauma victims. Today is a demonstration of our organizational commitment toward healing. In the 2 sessions, our entire network is going to develop necessary skills to deliver trauma-informed care. This training will promote the implementation of trauma-informed practices and programs and services throughout our network in the coming year. Clearly, any barrier that stands in the way of people achieving the lives that they need, full participation in community and recovery, are the focus of our efforts, and trauma is a significant piece of that. We are a network of healing, and we are a network of recovery. We are a network of self-determination, and the people in this room make all this happen. Nobody else, the people that we serve, and you folks, and that is, we need to make sure our skills are honed. So without further ado, I'm going to introduce the speakers today. I was told that I don't have to go through all the bios, but I'm kind of going through a few of them. But the first person I just want to introduce, who's going to be first up? I'll start there. Okay, Mr. Almanzar. He recently served as an acting director for the State of Illinois Department of Mental Health, with primary responsibility for the 1,958 inpatient beds operated by the state. A registered nurse by training, and for many years involved in the management side of hospital operations. He is also an administrator for the Elgin Mental Health Center, and was very active in the SAMHSA Restraint and Seclusion Reduction Grant. The second presenter, Beth Caldwell, is the principal consultant in a group dedicated to supporting children with special needs, their families, and organizations that serve these individuals so that each child can realize their full potential. For over 30 years, she has cultivated human service organizations throughout the country with her skills and experiences in training, technical assistance, administration. She is well versed in the interrelationship between mental health, substance abuse, child welfare, juvenile justice, and education. Mr. David Fuller is presently employed at Kings County Hospital as a forensic peer counselor who coordinates with the adult outpatient walking clinic and a group facilitator within their continuing day treatment program. He's an outreach and housing coordinator for the Manhattan Outreach Consortium and a former director of a supported housing program located in the Bronx. As we were speaking before, is that for recovery and barriers to full community inclusion are transportation, jobs, and housing. So the interconnectedness between our service delivery with all of those needed social supports and the focus on trauma is the content for today. So Mr. Almanzar, I want you to give him a warm welcome and thank you.
Good morning.
Good morning.
Oh, you got one?
You want to put up the CEU slide?
I don't have
CEU form slide.
that. I don't have
Yeah,
that.
Is that the form on how to fill out the CEU?
I don't have that.
At the end of the show, we're going to be ready for that.
Oh, okay. All right, thanks.
So first of all, kudos to all of you in terms of your commitment to trying, attempting to move your system, your whole system to become trauma-informed. I actually have been working quite a bit in Michigan, and I'm from Chicago, I'm from Illinois. And the work primarily has been in the state hospitals. We actually were at Cairo yesterday for a site hospital visit, and we have one more to go. We have Kalamazoo to visit. So I have to say that the whole state's commitment to this is pretty impressive. I think about 3 months ago, I did a presentation for is it Department of Community Health, I think is what you call your Office of Mental Health. And the person, I don't know, I think her title is Department of Human Services Director, or whoever is over community health, that's overseeing all of the health system. She came in and she said, you know, we're going to, I'll come in to introduce the speakers, but then I'll have to leave. So she introduced me and sat for a little bit and ended up staying for the whole session. And at the end she said, oh my God, what you're talking about has implication for every part of the system. And that's why I stayed, because one of the things she said is, which what I will talk about in terms of the ACE study, she said, wow, that has an implication for the obesity program that we're trying to run. So hopefully one of the things that you will get out of today is really understanding that trauma is not something we add on to what we're doing. The trauma really is the foundation of a lot of what we're attempting to do. The issue around trauma, I hope after today, you will go away not experiencing this as the next flavor of the month. How many initiatives have you had come down the pipe, new heads of state, new directors say, we're going to try and do this. They go away, the initiatives don't really take hold, and then the next flavor of the month comes in. So trauma really, hopefully, will be, you'll walk out and say, okay, this makes sense to be the foundation of what we do. Because if you think about it, if you take a child growing up, that child may go into child protective services. That child may have juvenile justice experience as a result of that. Foster care, may end up in mental health, may end up in substance abuse, maybe in corrections, maybe with law enforcement encounter. The fact is, what we have learned is that we are serving the same people. And what happens is that when people's trauma are not addressed in the service system that they're in, they get patched up and they move on to the next service system. How many of people that you see have come from different service systems and they just keep rotating? And that's what we're here to talk about today. And I have, the other kudos I want to give to you is I've never presented in a place where there's an open bar. That's pretty impressive. I have to say you're pretty progressive, especially in the morning. Okay. So let me give a brief background in terms of who we are, and as you heard, the three of us come from different parts of the country. We work under the Substance Abuse Mental Health Services Administration, SAMHSA, and but we also are under the National Association of State Mental Health Program Directors. NASHPID, a pretty weird acronym. NASHPID is actually the trade organization of all commissioners of mental health. So one of the tasks we do under NASHPID is that because every state contributes to NASHPID, we serve the commissioners of mental health. So we are consultants, and one of the things we do is that any state can call us and say, we have a problem. We need you to send people in. So I can end up showing up in Minneapolis because there's a labor management issue. I can end up in Connecticut because of high use of restraint seclusion. So that's one of our functions. The second part of what we do is we bid into grants for SAMHSA. And presently we're running 2 grants. One is the National Center for Trauma-Informed Care. And the other grant is called Promoting Alternatives to Seclusion and Restraints Through Trauma-Informed Practices. And that grant really is what's paying for us to be here today. Now, the reason I'm talking about that is it's a misnomer. That grant really crosses service systems. We do technical assistance in any service system, community mental health, domestic violence, juvenile justice, law enforcement, corrections were there. So one of the things that I want to emphasize today is during the presentation, if there are things that you think about, I would like to learn more about this, or I would like this type of program to come into my program, all you have to do is fill out 4 pages of technical assistance and we come to you for free. So that's an understanding that this is not just something that you may hear today, but also say, I want this to come to us, and it's possible. So, our contact information will be there. So anyway, we're talking about trauma. And how many, show of hands, how many of you do trauma assessments or trauma screening in your programs? A few, okay. So, I'll jump into this. So, when we're talking about trauma, the first thing is, what is trauma? So one of the first things, and I think most people understand what trauma is, you know, physical abuse, sexual abuse, and all of that. But one of the first things I want to point out in this definition of trauma is neglect. Neglect is a passive event. Not many people can come to you and say, I was neglected. So when we're talking about the trauma screening or trauma assessment, or the net we cast out there to try and capture the individuals that you serve with history of trauma, here's one group of individuals you may not be able to capture. Individuals with history of neglect. And as the DSM tells us, and what I want you to remember as we go through today's presentation, it's not the event that is traumatic. It is the individual's inability to cope with the event that makes it traumatic. The events overwhelming the individual's ability to manage it is what causes it to be traumatic. Therefore, one of the take-homes in all of this is we cannot judge what is traumatic or not, because we have different protective factors in terms of the experiences we have. I mean, I had a nurse in one of my programs not too long ago where she was walking into a patient's bedroom. The patient was coming out and she got hit between the forehead by the door. No physical injury, but was out for 6 months. And the staff were all going, oh my God, she's milking the system. Unbeknownst to them, there's history of trauma, and that triggered something. So one of the things I want you to really think about is when we hear stories, when we hear accounts of people's experience, we cannot judge what was traumatic or not, because we don't know the history of that individual. There are many different types of trauma. Of course, what we're talking about today mostly is developmental or complex trauma. But in communities, one of the things I encourage communities to think about is there historical trauma in your community? Because you practice within a community, and within that community, you need to identify if there's historical trauma. In that historical trauma, because what happens is the way that community deals with the world may be a result of historical trauma. And the repercussions of that in your work may be a result of historical trauma. I had the privilege of working in Hawaii system in the spring, and one of the things they said to me is, Raul, you cannot come to Hawaii and teach us unless you study our culture. I said, okay, I don't get paid to study the culture, but okay, I'll do that. And unbeknownst to me, I get there. I have never been to Hawaii, so I didn't know what I was going into. They still resent us having taken over their land. They still have bumper stickers saying, bring back the Kingdom of Hawaii. So it's the context that when I walk in there and talk about trauma, the context of people in that community still resenting people. And then I was in the Big Island, and I don't know how many of you are familiar with the Big Island. The Big Island has, of course, it's big, and there's a mountain range in the middle. But in the so the prosecuting attorney was was my host. And the prosecuting attorney said to me, do you know that the Big Island has the highest teen pregnancy rate in any county in the United States? I said, no, I didn't know that. And she said, let me explain this to you. She said, there is no ferry system that can get you out of the island. You now have to fly between islands in Hawaii. So you have to have money. You have to have money to cross that mountain range. So think about these communities where there's abuse, incest, and a lot of things happening where people cannot escape. Because of, if you don't have the money, you cannot escape. And therefore, what happens in there is that intergenerational trauma of things get to be acceptable. Because it becomes part of the culture. So are there things like this in your culture where you're practicing that affect the way people look at things? The last story I have with this, I just met a psychologist in Alaska. He's practicing an outpatient, and he said, sees a lot of juvenile justice individuals. And he said he has a client right now who he's dealing with significant self-esteem issues because she comes from a frontier community, a very small community, and she wonders what's wrong with her because all of her friends are getting sexually abused and she's not. Think of cultures. Think of what happens out there and how that affects people. So we're talking mostly about developmental and more complex trauma, but make sure that as you walk out of here, you also look at what are the traumas in your community that affect the way people look at the world. Okay. I also want you to know I tend to not follow my own slides, so we'll keep going. So anyway, I will do a little bit of data for you guys. So let's talk a little bit about different types of data. Okay, the mental health population. 90% of public mental health clients have been exposed to trauma. These are all in your handouts. I'm not going to go through all of this. In adults, the majority of adults diagnosed with borderline personality disorders or dissociative disorders are sexually or physically abused as children. Do you, I assume you guys encounter individuals with borderline personality disorders? Okay. Actually, John Greer of the National Child Trauma Stress Network talks about not believing in the borderline personality disorder diagnosis, that he really believes in having studied trauma, that almost all of those symptoms are trauma reactions, are trauma-based symptoms. In children and adolescents, show of hands, how many of you treat the youth, children and adolescents in your programs? Okay, quite a few. Okay. An American study of 100 adolescents, about 97%, or 93 had trauma histories, and 32% had PTSD. Now, the piece that I want to point out here is that what's clear in our statistics is that not everyone who has trauma history develops PTSD. So what we're talking about today, again, is looking at that wide net of who are the people we are treating with significant trauma history. In the substance abuse population, how many of you are running substance abuse or current programs? Oh, okay. Good number. Okay, so up to 2/3 of men and women in substance abuse program have reported childhood abuse and neglect. Sexual trauma and addiction. In a 208 study of African American women, those with history of sexual trauma reported being addicted to more substances than those without. Juvenile justice settings. At the bottom, the 2003 Office of Juvenile Justice program study of youth in residential placement, 7% had history of traumatic experience. So I can go on and on, but basically what we're trying to point out here is the majority of individuals you serve have history of trauma. And I go back to the piece about neglect. earlier. I'll go back to it. But the last bullet point here is, I think, what's really important. There's a significant study that shows a strong relationship between victimization and later offending. So when we're talking about trauma-informed care, we're not just talking about providing better care. We're talking about a moral imperative in each of you to stop the cycle of violence. That's really what we're here to talk about. We're here to understand that unless we practice in trauma-informed systems of care, that cycle of violence will continue. Sandra Bloom, a prominent psychiatrist who developed the sanctuary model, talks about hurt people hurt people. That's what we really are talking about. We need to look at these systems of care and how are we able to break the cycle of violence within the people we serve. So we agree that victims of abuse are found across all systems of care. So what do we promote? So first of all, I said that there are the individuals with neglect that you may not be able to capture with your trauma screening or trauma assessment. Individuals who experience abuse or trauma before language develops will not have the language to attach to that trauma. Those individuals will not be able to capture either. And there are many individuals who are not ready to speak about the trauma, who will not be able to answer yes to your trauma questions. So what we promote is to practice universal precautions. Just assume that everyone you encounter in your system have history of trauma. Now, I assume you guys practice universal precautions, infection control, right? You see blood and bloody fluid on the floor, you don't touch it, you put on gloves, because you assume everyone is infectious. So what we're really helping you understand is what we're promoting is a public health model that says because you do not know the trauma history of the people you serve, just assume that the person you're encountering has history of trauma, which makes sense for you then to not just develop a trauma-informed care, but a trauma-informed system of care. That's why when we were setting up this program, one of the things we always say to individuals who request our assistance, we need you to bring as many people as possible into the trainings, as many service systems as possible into the training, because we need to be able to cross all service systems, because we practice universal precautions. The other significant statistic I want to point out is that in the general population, 61% of men and 51% of women have history of trauma. So folks, statistically, that's half of the people in this room. Statistically, that's half of your workforce. So when we're talking about a trauma-informed system of care, we're not just talking about the people we serve. We're talking about the people that work in our programs that also have history of trauma. How many of you have watched staff interacting with a client and you watch sparks fly? What happens? You know, as we talked about earlier, it's that what makes an event traumatic is that it overwhelms the person's ability to cope. So, what is the most common trigger with individuals with trauma? Is loss of control, right? They don't want to re-experience that feeling of loss of control. So what happens when you have a staff member giving a client a directive, and that staff member is very sensitive to loss of control, and the client is sensitive to loss of control? Someone's got to win. They are going to go at it until someone is going to win. So when we're talking about trauma-informed care, we're not just talking about what happens to the people we serve, but we're also talking about the staff. And if statistically half of your staff came into your programs with history of trauma, how many of them have been traumatized within the programs? So when you're really thinking about trauma-informed care, you're thinking about the whole program and what's happening in the program. So, so this is what the schematics I use to help people understand. To be trauma sensitive or trauma focused, most places will provide trauma screening, trauma assessment, or trauma treatment. That means you're being sensitive to trauma and focused on trauma. When we're talking about trauma-informed care, we are talking about a system that begins to practice universal precautions. So when we're talking about trauma-informed care, it's not just identifying people who have trauma. And the other piece that's really helpful with this is because when you talk about trauma-informed care, a lot of places would hear this and say, oh, that's a social worker. It's not my job. That's a therapist's job. So when we're talking about trauma-informed care, it's a job of everyone. One of the things that we really, for example, I like to train programs where the front office staff, if they understand trauma-informed care, they have a perspective of why that person is going off in the lobby. Why that person is upset because your program has people who walk in, get numbers, and that person got number 33 today. So when we're talking about trauma-informed care, we're talking about every part of the program. When I was running my program, I had patients coming back upset. My staff were good, but they come back upset and they take it out on the unit staff. Unbeknownst to me, my drivers were rude. They didn't understand how people respond and get triggered by trauma. So if the parts of your system do not understand this, it's not going to be effective. So when we're talking about a trauma-informed system of care, we're really talking about the whole system, both individuals serving and individuals being served. We're talking about a trauma-informed system of care is steeped in collaboration and partnership. It's non-controlling, and that it provides hope and healing so people can recover. Now, the other reason I use the schematics that I help, that people have found helpful is that whatever flavor of the month you're running, whatever initiatives you have, it is helpful to have something like this where you fit that into the larger picture. If your staff are not able to see where your initiative fits into the system, we begin to talk about organizational trauma. That's the other piece that we talk about. The chronic stress in systems. So not only do staff in organizations become traumatized, the organization itself becomes traumatized. And then you have organizations that begin to react and begin to act in ways as if they were traumatized individuals. How many of your decisions that you make in your organizations are based on incidents or sentinel events that have happened in the past? How many decisions or creative ideas come to your program and the response you get is, yes, but do you remember what happened in 1999? That can happen again. When you think about trauma, you think about what happened in the past affects people's choices today. That's true of individuals, it's true of the staff, it's true of organizations. That's why when talking about a trauma-informed system of care, we're really looking at organizations as well. So one of the tips I give organizations, for example, how many of you have sat in staffings or treatment team meetings where you disagree as to how to approach an individual? One side is going, oh no, you're being too lax. Oh, you're being manipulated. Oh no, you're being too harsh. Because we all come from different points of view. We all come from different orientation. But one of the beauty of the schematics is it helps us stop the process and just ask, how will it help this person heal? If you just keep asking that question, how will it help the person heal? You go back to why we're doing this work. So that's really what trauma-informed system of care is. It's really understanding again why we're doing this work. How many of you have heard of the ACE study? Okay, great. We got one or two. Okay, so the ACE study is, it started out as work out of Kaiser Permanente out in La Jolla by Dr. Felihi. and his partner, and they were running a weight loss program. And in the weight loss program, they were noticing that people were not only dropping off the program, but some people were regaining weight. And the people who were dropping off were losing weight. So they studied it, they looked further into what was happening. And one of the things that they found out was common in all of these individuals was a history of adverse childhood experiences. That's what ACE stands for. Adverse childhood experiences. History of trauma in the past. So their study ended up switching to looking at ACE. They looked at 17,000 individuals within the HMO program. And this has been picked up by the Center for Disease Control and because of its implications to American people's mortality and morbidity. And it's been replicated in many programs. So what the ACE study basically is, they looked at 10 items as the most common adverse childhood experiences. And if you look at the items, it's not your typical trauma questionnaire. It's not just sexual, physical, neglect, types of abuse. You look at this, it asks about separation or divorce. That can have traumatic experience for children, don't you think? So if you look at this, it's not that hard to score in an ACE study. So basically what it is that for every item that you check, you get a score of 1. So you can get anywhere from a score of 0 to 10 in the ACE study. So what have they found in terms of adverse childhood experiences and what happens to individuals 50 years later as a result of adverse childhood experiences? So, emotional problems. The higher the ACE score, the higher the likelihood of lifetime history of depression. Okay? The higher the ACE score, the higher the likelihood of suicide or attempted suicide. Look at the difference between a score of 4 and a score of 1 in terms of likelihood of attempting suicide. ACE score and hallucinations. How many of you have begun to read a lot of the new data coming out that more and more scientists believe a lot of hallucinations are actually jumbled up flashbacks as a result of individuals' history of trauma. Impaired memory and childhood experiences. You see, it's not only a correlation, it's a graded correlation. As the ACE score goes up, so does the likelihood of things happening going up. Health risk behaviors. ACE score and smoking. This is why the CDC, the Center for Disease Control, got really interested in this, because they said, why? You mean if I know the person's ACE score, I can predict their likelihood of smoking, which means I can predict lung cancer and early death. Just by understanding the adverse childhood experiences of the people we serve. The ACE score in adult alcoholism. The higher the ACE score, the higher the likelihood of adult alcoholism. ACE score in intravenous drug use. This graph, what that graph shows us is that a male child with an ACE score of 6 is 4,600% more likely to become an IV drug abuser than a male child with an ACE score of 0. 4,600%. That's why Felitti in his work asks us, could it be that drug use is really an attempt to help people deal with the profound anguish of childhood experiences? Serious social problems. The ACE score and the likelihood of getting raped. One of the things I ask folks when I go through this presentation is, I want you to imagine yourself as a 7-year-old growing up, where your protector is also your abuser. And I want you to try and imagine what kind of world you will have to develop for yourself to manage your world. So in that scenario, if you are growing up in a household where your protector is also your abuser, the red flags of danger doesn't develop as well. So it's no surprise that people will be in dangerous situations and their likelihood of getting raped is higher. It's how they don't develop the red flags growing up in terms of dangerous situations. I use this a lot in emergency rooms, especially for emergency room nurses, to understand that people don't choose to be raped out there. They may not know that they're in dangerous situations as a result of their time of history. Victim of the ACE score and the likelihood of being a victim of domestic violence, obviously higher in women. And the likelihood of being perpetrators of domestic violence, higher in, if you see, it's not much higher in men than it is in women, which is a fascinating data to start with. Likelihood of having 50 sexual partners. How many of you work with individuals who provide HIV/AIDS treatment? Okay, great. We have a few spending a lot. I've been spending a lot more time with HIV/AIDS programs, exactly for this reason. I mean, how many individuals that you encounter in your program, especially those with substance use, say, you know, when I need to get high and I have to sell my body for sex, I don't stop and say, wait, where's the condom? These kinds of thinking doesn't necessarily happen, and Beth will talk more about what happens in individuals. Okay, I'm getting the 10-minute sign. So anyway, elective abortion, unintended pregnancy and elective abortion, history of sexually transmitted diseases. So, what are the significant implications for this? So, the question then is addiction really experience dependent, not only substance dependent? So, what are the implications for a study? And there are a few. So, for example, one of the things Fellini talks about, I was talking to Jeff, and some of you are really working hard in integration of physical and behavioral health. Think of the implication of this, integrating physical and behavioral health in your programs. So, Fellini asks, for example, an internist sitting in his office, seeing a client every 6 months. Every 6 months, that person is still obese, he's still smoking, he's still probably has hypertension, so gets antihypertensives, probably pre-diabetic, gets medication for that, probably has high cholesterol. And he asks internists, if this person keeps coming back doing the same things, if you understand the case study, it's time to refer. And understand that there may be reasons why this person cannot give up the issues that the internist is asking them to give up. Because, so the other part of the ACE study, which really helps us in understanding what happens to individuals with trauma, is we talk about symptoms then are adaptations. They're attempts to survive in the world. Symptoms as adaptations. I want you to think about when you have a really hard day at work, what do you do to relax? Some people exercise, some people read. I was in a school teaching at a school the other day, and it was really cool. The principal was sitting there, and she really looks like a principal. She's about 65 years old. When I asked her the question about what do you do to relax, she said, I play video games. And people just looked at her like, what? She's like, oh yeah, you should see my video game. But we do what we need to do to manage. I eat a bag of potato chips. Right? So we do what we need to manage in this world. And what we do every day doesn't always work. If it's a harder day at work, it's usually a bag of potato chips with a glass of wine. We do what we need to do. So what we're really talking about here is that one person's exercise, one person's reading a book, my potato chips is the next person's cutting, the next person's alcohol, the next person's crystal meth. It's all adaptations. So what trauma-informed care is really trying to help us understand is take a look at the people and we stop looking at their symptoms as just symptoms. They're attempts at adaptation. There's a program in Hawaii, in Missouri, it's, that we've worked with. It is a maximum security program for individuals with intellectual disabilities who are highly violent and self-injurious. Okay? Think about this. But in that program, for the staff to work in that program, they have to sign an agreement. And the agreement states, to work in this program, every day I will work with the assumption that everyone in the program is just trying to do their best. Think of how your programs would work if everyone walked in there just thinking everyone is just trying to do their best.
That's right.
Another implication in terms of symptoms is adaptation. Working with San Mateo County up in the Bay Area, they have developed a trauma learning collaborative. Very impressive. I don't have the time to really go into what they're doing. But one of the outcomes, and this is a great place to talk about this, one of the outcomes in their program is they have developed countywide a no abandonment policy, which basically states if someone relapses, there's probably something going on in their lives that caused them to relapse. Therefore, no program is allowed to discharge as a result of relapse, because that is abandoning people when they need us the most. Think about that. That is how the systems begin to shift when you understand symptoms are adaptations and how are you managing that? Or are you still so consequence-based that we forget that people are just trying to do their best? So I think the other issue around the ACE score, and to go back, and I'll end with some of this. So the ACE study, okay, one of the strategies around the ACE study, more and more programs I've gone into are using the ACE study, the ACE questionnaire, it's in the public domain, as a screen for trauma because it's easy and it's not very stimulating. I have seen programs give the ACE questionnaire to staff on orientation. They don't ask for the results back, but it's a way for staff to understand at the front end there's stuff you're bringing into this program. And we help you make aware of what that is when you're coming to our program. So think about that. More and more programs that understand symptoms as adaptations and staff trauma, have staff identify their own triggers. How would you like to work in a program? Because we cannot be empathic to 100% of the clients we serve. There are people who get under our skin. How would you like to be in a program where people understand who gets under your skin so your coworker can tap you on the shoulder and say, let me take over? We're human. That's what trauma-informed system of care is. Understanding the humanity in the systems of care that we I was in Upper Michigan, and I was talking about the no abandonment policy. The substance abuse providers came on and said, well, we would love to practice this, but our prosecuting attorney is so unempathic. He relapses, he throws people in jail. And there's nothing we can do about that. I said, there's nothing I can do about it either. I'm just at the center. Hopefully, the prosecuting attorney was in the audience. Hopefully, he's listening. At the break, prosecuting attorney comes up to me and said, Raul, I scored 6 on the ACE score. I begin to understand why I cannot show empathy. It'll be too close to home. So understanding trauma-informed system of care is understanding the humanity in the service systems, the humanity in the people we serve, in the people providing the service, and in all of us. Thank you. I promised to introduce Ben Caldwell. So you. Oh, we're giving a break? Okay, 15-minute break? Break.
System of care, and it's for 3.5 contact hours. And then as you leave, we will initial you out, and you will take the yellow copy, you will keep the white copy. Okay, thank you. It's on the screen. Where is that? Can't see it. It's moving toward a trauma-informed system of care, and it's for 3.5 contact hours. Okay, Beth, thank you.
Good morning, everybody.
Good morning.
How are you doing?
Well.
Wasn't Raul wonderful? Yes. So I live in Massachusetts, but not Eastern Mass where the Red Sox are. I live in Western Mass where everybody's a Yankees fan. And when I think of Michigan, and I've worked here a number of times doing training or consultation, but one of the things I think about, or two things I think about, I don't think about automotive industry. I think about Interlaken, the wonderful, I think, almost many people in Michigan must be musical geniuses. And then I also think about all of my smart friends seem to have gone to the University of Michigan. So when I think of Michigan, I think everybody must have a high IQ and be really good playing music. Is that true? So how very impressive that you all are going to be one of the first counties in the country that is truly trauma-informed. This is extremely impressive. I would like everybody to turn to a neighbor and say, I am so cool. Go on. And psychological impact of trauma, and the relationship really between trauma and what Raul started, you did bring up a little bit, between trauma and a focus on control. Dr. Glenn Sachs he actually was at Harvard, he's now at NYU, New York University, but he has done the lion's share. Way back in 2002, we started the work a little bit before that. He's done the lion's share of this work, and what he talks about is that he shares for him that this initiative of SAMHSA, this initiative about moving towards trauma-informed care, he shares for him it boiled down to morality. He feels that it's a moral issue when you're serving people who have been traumatized, that we have to treat them right ethically. So, for instance, if you have a young woman who you're serving and she has a history of sexual abuse, and because of that history she has discontrol problems, and yet staff raise their voices at her, point their fingers at her, or really frame their interactions with control, he says that this is against the Hippocratic Oath. When we are controlling with traumatized individuals, we actually do more harm as opposed to doing no harm. I want to also acknowledge the National Child Traumatic Stress Network, which, like this training, is funded by SAMHSA, and there's now about 53 trauma centers around the country. Much of the research that I'm going to be citing in the slides today actually come from some of the work that's happened out of that initiative. And I also want to just share with you how committed Dr. Glenn Sachs was. He was actually the medical director of an intensive residential treatment program in Massachusetts. And he decided, because of his commitment to trauma-informed care, that this stuff they were doing there, which included, you know, physical restraints, mechanical restraints, seclusion, and chemical restraints, he was going to stop it. And he started this journey because, again, of clinical and ethical reasons. And one of the things that we're finding across the country through this work with SAMHSA, in fact, just last week at a big kickoff in Massachusetts of their adult psychiatric hospitals that are revisiting, moving towards elimination of restraint and seclusion. I had two hospitals, one in Oregon, the CEO presented, and they had eliminated restraint and seclusion many years ago, and they still don't use it. And so it's really about moving towards what Raul's talking about, this kind of compassionate framework. So what they found also in these hospitals, as they reduced in residential programs restraint seclusion, what happens is staff injuries went down also. You know, in fact, some of the things they're finding is that you save lots of money when you don't do this. And not only do staff injuries go down, but injuries to the persons we serve go down. People like their jobs better, and there's less recidivism. So children walk to their futures on the pathways cleared by the adults in their lives. And the people you are serving, in part, are walking to their futures by the paths you're helping to clear for them. So the question is what kinds of paths are you clearing? How are you doing that? And so we want to look at a trauma-informed care approach to that. This is another way of looking at pathways. This is one of, this depicts some children, or a slide of children in a medical hospital, and they are actually in the hospital because of severe burns to large parts of their bodies. And this is kind of the first take-home lesson to trauma. And I am sure with how many smart people we have in Michigan that many of you have already been exposed to a lot of this. So if in fact you have been, have also become an expert in some way about trauma, about the neurobiology of trauma, know that you can use these slides that we're giving you, that you can request copies and use them for your own training purposes. So just use this if you already are an expert to actually add to and use to support others in gaining their expertise. So basically what they found, and the first part of the slide, the first point is at admission, and the second point is 3 months later. And using the post-traumatic stress disorder index scale, they found that the children in burn units actually all responded individually to their burn traumas. As you see, some of them started with high rates of PTSD, went down over time. Some started with low rates, it went up. And basically, it's our first take-home lesson again, is that everybody, depending on their neurobiological makeup, their physiological makeup, their historical makeup, is going to respond differently. And here we have a slide from it's called the end point of trauma. And this is one of those famous studies. It was done at Duke University by a scientist named Dr. Michael DeBalis and his colleagues, and they were using MRI technology, and they basically identified damage to the brain. What they were doing is they were comparing the brains of children who had a history of trauma and those that did not have a history of trauma. So for you all, the child with the history of trauma is on your left. Well, would that be on your right? Yeah. Right. It would be on your right. Okay, so the left of the screen. And the child with the did not have a history. Do you see a little bit of difference there between these brains? So what they found is that there is actually atrophy the amygdala and the cortex, and particularly the frontal cortex, and the intracranial and the cerebral volumes, kind of the CEO functions of the brain, were up to 8% smaller in subjects with PTSD. So there's this loss of that frontal cortex, that CEO part of the brain. Pretty amazing and pretty sad, actually. Kirsten Conan, who's actually out of Boston University, she did a study with over 500 sets of twins. They did this in the UK. And they were 500 sets of 5-year-old twins, it's an amazing study, who were discordant for trauma abuse. One had a history of trauma, one did not. And what they found is that the twin with the trauma history actually had an 8-point reduction in IQ, minimum 8 points reduction, with the only variable being that trauma. So the pathway of traumatic stress is really filled with tragedy, and what we want to do is really get our heads around this. So I'm going to be talking about this report. If you have not Googled this report, I suggest you do Google it. It's called Neurons to Neighborhoods. And it's from the Institute of Medicine. It's really about, there's a whole part of this report that talks about how each of us grew up to be a successful adult. Now, I'm thinking probably all of you are successful adults. How many of you pay taxes? Okay. How many of you have to pay a mortgage or rent? Okay. How many of you have to pay for transportation? Okay. And how many of you have ever been upset at work? Anybody upset at work? And did not throw a chair? You're a successful adult, okay? So this will tell you, we're going to be looking at some of the principles of this. So basically, Raul gave you some idea about the prevalence of trauma, so I'm not going to go through these next couple slides. But how about, has anybody ever served anybody who had ADHD? Yeah. Well, Dr. Mark Katz from the University of California at Santa Barbara actually has done some interesting studies with children with ADHD. Any nurses in the room? Okay, so we've got quite a few. So my son just became a nurse. Isn't that cool? So you probably think I'm too young to have a son that old. Anyway, so Mark Katz did this study, and he took children who had ADHD and children who did not have ADHD, and they were all lived at home and were going to school, a community school. And he took a sample of their blood every day, both of the groups of kids, and after they got over getting samples of their blood taken, he started to measure their cortisol level. So if you're a nurse, you know if you measure their cortisol level, you can measure what? Stress, right? So the child with ADHD, every day going to school, had a higher stress level than somebody who just had been in a major car accident. And when you think about that, going to school every day with that kind of stress, wow, is that going to change whether or not you're going to get an A in math or not? Probably. So what we know from all of these different studies, and I'm just going to go through some of, you can read these later tonight when you go home and get in bed with your significant other. You can go back through these slides. But what we know, as Raul talked about, is that many, if not most of the people we're serving have had experienced trauma. And as Sandra Bloom, who is that wonderful psychiatrist who has dedicated her life really to studying and to working on this, what she shares is hurt people hurt people. Hurt people hurt people. And so if we're going to really support the people we're serving, we need to stop that cycle. So what do? There are two general principles regarding traumatic stress. One is that the individual who you're serving has a dysregulated emotional nervous system. And the second part is that the social environment, which could have been their family, their community, their work, was not able to support them in containing that dysregulation. So we want to be able to look at both of those things. So we're going to be talking about these 6 core concepts of development from this Neurons to Neighborhood report. And the first one is basically, we're born and our life starts to unfold. How many of you have children who are over 14? Okay, think back to when that child was born. Did their life unfold exactly as you wanted it to? No, you know, there's trajectories. And as I showed you before, whenever there's trauma of some sort, okay, there's going to be some sort of trajectory. And so actually PTSD, post-traumatic stress disorder, again, Raul talked about this, but we're reinforcing this. This is the definition. But you know, it's really not only that it happened to you, but it could happen that you witnessed it. And how is it characterized? It's characterized by actually re-experiencing. It could be flashbacks, it could be nightmares that we're not aware of. It's characterized by avoidance and numbing. I was just, you know, I'm always, Raul and I have worked together for many years, but I love this, don't love, but I appreciate the story about the district attorney. You know, I mean, what was he avoiding, right? When he talked about that. But what's also important to know is that these flashbacks and could really lead to what we call out of control behavior. Has anybody served anybody who has had out of control behavior? Yes. You know, so it's very interesting how it all connects. And so it's these symptoms, you know, of PTSD can really lead to people not being able to what we're going to talk about in terms of calling self-regulation. So what we really want to do is focus on supporting people to self-regulate. This is the second core principle from the Neurons to Neighborhood report. The reason you are a successful adult is because you can self-regulate. Bessel van der Kolk, and I'm not sure if many of you have heard of him, but if you have not, I highly recommend you Google him. He's actually on my short list for my next husband. But he is I think, a genius, and there aren't that many geniuses around other than, he probably went to the University of Michigan. But he actually has done a lot of research on trauma. And what he shares, after all of this research on trauma, he shares, you know, the most important thing you can teach your own children, is how to self-regulate. Because if you can self-regulate, you can do anything. So the reason you're a successful adult is at some point in time, you learn to self-regulate. And we already found it's an internal process. And so what we want to talk about related to traumatic stress is really kind of this connection between what we're going to call calm and continuous states and discrete states of emergency. So this is a slide courtesy of Dr. Glenn Sachs again, and this was one of his clients. His name is Robert. Robert had a severe history of physical abuse by his stepfather. He was actually in a psychiatric hospital at this point in time. He was in a calm, continuous, engaged state. I wish I had, maybe I do have one of those little pointers, you know, so you can see he's kind of in this calm, continuous, engaged state. He's on the hospital floor. He's actually having a good day. And then what happened, and this is where self-regulation did not occur, is he went from calm, continuous to a discrete state of emergency. So he immediately, he's on a psych hospital floor, and the staff, he was fine 1 minute, and then boom, he went and started to attack a staff member. So what used to happen in most hospitals, and still happens in many, when you would begin to attack a staff member, what did they do? They restrained him. So he went to a second state of emergency. When he's being restrained, he actually began to relive what? Being abused by a stepfather, and then he went to a third state of emergency. So it's fundamental for you to understand this what's happening, the transition between states. So Dr. Glenn Sachs did meticulous interviewing of Robert after this event. And what he found out is that he was having a good day, and then he heard a staff member say something, and he thought it was something that he said was demeaning about him. And whose voice did he hear it in? The stepfather. So he went from, anybody see that 0 to 60? you know? And so he immediately, there was not this self-regulation. It did not occur. So the transition between calm and continuous states and discrete states of emergency are fundamental for understanding traumatic stress and its neurobiology. Here's another example. This is a 12-year-old girl, again, courtesy of Dr. Glenn Sachs. She has a history of sexual abuse, but she's living at home, going to a community school. She's having a good day. She's in that calm, continuous, engaged state. And then what happens with her, and again, it was meticulous interviewing from Dr. Glenn Sachs after this event happened, that she went like this to a state of emergency. Because what happened is that she's sitting in her chair at math class. A couple of you look pretty young. Do you remember being 12 sitting in math class? You know, you're sitting there in math. She's having a good day, and then all of a sudden the boy sitting next to her leaned over and said something demeaning to her about her breast. And here's again an example where self-regulation did not occur. She immediately went to this sense of emergency, stood up, walked out of the classroom, and started feeling this intense shame. Self-regulation did not occur, the transition between states. And then as she's walking down the hallway of the school, what does she begin to relive in her head? Being raped. And so she goes to a second state of emergency, just like Robert did. She walked out of school. She actually lived quite close to the school, walked home, used her key to open the front door, went up the steps to the bathroom where she hid what? The razor blade, so she could begin to disassociate too. So it's another example where self-regulation, the cornerstone of development, did not occur, okay, because this transition was impacted by their trauma. So it's fundamental when you see anyone with a trauma history have a behavioral or emotional discontrol, this is what you might and often are seeing. So if you think about Robert or even the young girl right before, he was fine. He was thinking he was fine, his behavior was fine, and then right after it was different. So all of these states change because self-regulation did not occur. All of this is built on really normal developmental principles. This is how we all come into the world. There's this wonderful scientist, Peter Wolf. He's actually from Harvard, and he studies young infants, okay? And what he finds is young infants have actually definable behavioral and emotional states. Very interesting kind of work that he does, and he's actually informed the National Child Traumatic Stress Network. So how many of you have children of your own? Okay, many of you do. Wondering what you did in the long winters in Michigan, okay? So you have a baby, you bring that baby home from the hospital or from the birthing center, or you have that baby at home, okay? And you get the baby's home and the baby starts to cry. What do you do? Pick it up, I heard. What else? Might feed it, might change it. Does anybody, you could pick it up, did anybody move a little bit with that baby?
Sure.
Did anybody rock their baby?
Sure.
Okay, did you rock that baby 15 times over the course of their young life? How many?
A lot.
Thousands, right? So what Peter Wolf has found, so all of you whose parents grounded you when you were teenagers, it didn't help. Okay? Because the reason you started to make good decisions was because of this self-regulation. What Peter Wolf found, it's an internal mechanism. So what happened is that over time, that baby would be in a calm state and then go to a state of distress. Maybe they were wet, maybe they were hungry, maybe they just need to be held. And then what happened? You would pick them up and you would rock them and move them, right? And then they go from distress to what? To calm again. But what happens with trauma is people that disrupts that kind of emotional nervous system that's kind of our natural reaction, well, other than our significant others, right? But, you know, to go from calm to stress back to calm again. Any of you, have you ever gone from calm to stress to emergency with your significant other? Yes, you know, you lose like 25 IQ points when that happens, so be careful of that. So, but people with trauma often then go to this lifelong habit of going from calm to distress to emergency states of behavior. versus being able to do that, that self-regulation. So this is our goal of treatment. This is kind of the overall goal of what we're looking to do, is we want to maintain in your physical environments, your offices, when you're meeting with people, you want to support people in maintaining these calm, continuous, engaged states. You want to prevent these discontinuous states, and you want to build cognitive structures that allow choices. I understand that each of you are on the way to choosing different evidence-based trauma-informed care approaches. I think that's fantastic. But so this goal of treatment, the following slides illustrate this. Let's say you have a stimulus, and it could be any stimulus. Say it's Robert, and he hears his stepfather's voice, and then he goes from stimulus to response without thinking. So what we want to do is to build in with the people we serve, first our neuroregulatory interventions. These are the interventions that help people to have the capacity to soothe themselves, to calm themselves between emotions and between states. People who have trauma have these big deficits there. The second, though, is the social environmental. How do we create, even in our own offices, do any of you serve people who come into an office? You know, how do you create an office experience that when people come in, all of a sudden their blood pressure goes down? At Cape Cod, if you want to go to Cape Cod and write it off, next summer, go to the Cape Cod Hospital Psychiatric Emergency Room, and as you walk in there, first of all, it's painted really soft colors. This is Psychiatric Emergency Room. Secondly, they always have either popcorn or brownies in the microwave, so you're smelling something, right? They have dogs and they have peers. Okay, so when you're walking in, and then they have these little sensory items around. What happens to your blood pressure when you walk into a church or a synagogue or a mosque? What happens? It goes down. Are we creating environments where people walk in and all of a sudden they can sense from the physical environment that I'm going to be cared for here? Somebody respects me enough that I'm going to be cared for here. So we're looking at those two things, and then what we can do when we're working on these neuroregulatory interventions and these social environmental interventions is that we can actually then can build this wedge of cognition. What Dr. Glenn Sachs used to do, and he at his residential treatment facility, and he actually now has something called trauma systems therapy, which is a wonderful framework for really putting all this into action. And you can Google trauma systems therapy. But what he would do with his adolescents is ask them in meticulous detail, and I don't mean once or twice, but multiple times, what are things that trigger you? What are things that make you, kind of move to that escalation? So that he's really supporting the people served in understanding their own triggers. And when I first was exposed to this a number of years ago, I was thinking, and I don't remember if it was my fourth or my fifth husband, but he had a grandfather who was from Russia. And when he was in Russia, he was this amazing craftsperson, and he would build these ornate pieces of furniture, and he was known far and wide in these villages for being this amazing craftsperson. Well, what happened is that he had to escape Russia. And he came to the United States, and the only job he could get was in a furniture factory putting spindles on chairs. And when I heard his history, I thought, gee, this is something comparable to us in the field of mental health and substance abuse. How many of you started in this field because you cared about others and you wanted to make a difference in people's lives? How many of you? Come on, all of you, right? You didn't get in this field because of the money. I know that, okay. And yet, how many of you sometimes have felt that you become a paper pusher or a rule enforcer? And so what we want to do is you are a craftsperson, and that's what we want to get back to. We need to help staff view themselves not as factory workers, but really as crafters of environment, as healers. And that leads to this third developmental principle. The only reason I put this up here, this particular one is 12, we're only going to review, I think, about 6 of them. is that this whole notion of nature versus nurture is a false dichotomy. What we know is experience sculpts the brain, and people with different brains choose different environments. And so what we're going to really almost further do is almost support people in sculpting their own brains. So to further highlight this point, there's a young man right here. Raise your hand, sir. I took his picture. This is his picture, right? During the break. You look good, don't you? Right? Okay. So there's, you know, all these different parts of the brain, and there's, you know, because I know very little compared to everything about this brain, but there's a few things that are really relevant for all of us. One is that there's two parts of the brain we want to look at. One is that the amygdala. It's on either side of the brain, kind of like right here. And anybody remember what it's responsible for? Like fight or flight, freeze, you know. So if I say amygdala, I want you to say fight or flight. Amygdala. Fight or flight, okay. And then kind of behind it is the hippocampus, on either side of the brain is the hippocampus on both sides. It applies context to the situation. It kind of regulates the amygdala. So between the hippocampus and the cortex, we have context and we have memory. So if I say hippocampus and cortex, I want you to think or say context and memory. So hippocampus, cortex, amygdala, fight or flight. Okay, so let's walk through how the brain operates. Let's say a stimulus comes in. It could be any stimulus. It could be Robert who heard his stepfather's voice. It goes to a place in the brain called the sensory thalamus. You know, this happens in less than 15 milliseconds. This is how all of your brains operate. And then there's two pathways right after that. One, it goes very fast to the amygdala. This is, again, a less than like another 10 milliseconds later. When I say amygdala, what's that for? Fight or flight. But within another 10 milliseconds, guess where it goes to? The hippocampus and the cortex, which is responsible for what? Context and memory. And this is how your brain operates. Your memory, how, you know, the context regulates the amygdala, and that's why so many people in Michigan have high IQs, okay? Because this is how your brain operates. So, but let's look at applying some of the studies, and there's been multiple studies on how trauma impacts the brain, to this whole dynamic. And let's say that there's trauma that happens, and I'm not sure if these slides are working like they, or you can see them very well, but what happens with trauma is a pathway to the amygdala, which is responsible for context and memory, is actually much faster, okay? So it goes much faster. But then the pathway to the hippocampus and the cortex, which is responsible for context and memory, actually is going much slower. And then the other slides have actually shown that the cortex and the hippocampus have actually atrophied. So when you're thinking of a person with a history of trauma, this is often how their brain is working in the context of being, you know, having an emotional trigger or trauma trigger. So let's put this into like reality. We're in this room together. By the way, this is a really nice room. Can we stay for the holiday party tonight, Julie? Anyway, so we're in this room together, and all of a sudden we hear a big bang, like a door slamming. What do? You jump. Your amygdala went like this, but your context, your hippocampus and your cortex said, oh, I'm in this room with this really good-looking young woman, right? Training, everything's so good. And what happens is you just kind of calm down, right? It went like that. But what if Michigan ended up having a ton of money, and they decided to send all of you to New York City for 3 days? But we're going to do this training in New York City, and they're having the training on like the 88th floor of the Empire State Building. And we're all doing this training, and all of a sudden you hear a loud bang. What would you do?
You go down the stairway.
Yeah, how many of you, even if somebody was standing out there in the hallway saying it's nothing, would say, I am out of here? Yeah, because how many of us were traumatized by 9/11? Our cortex and hippocampus aren't working. We are thinking, I am out of here. Okay, so this is how the brains of people who have trauma sacrifice context for speed. So we need to build in structures to support the people. We need to build in, again, these social environmental interventions that we really look, is our place of work a healing place? Is it a healing place physically? Is it a socially, you know? How about how many, even when we were working with New York City and their HHC hospitals in the emergency rooms, just doing things like making sure, because they have these little bitty interview rooms, and sometimes there's 2 or 3 people being interviewed at the same time in their psych emergency rooms, just doing things by adding some pillows in there, adding little baskets of little stuffed animals, and things that you can smell like lavender and squeeze balls, and you know, just really having soft music going in the background. What does that begin to do? So what about your social environmental and surveying your environment to diminish signals that cause distress, and then actually also, you know, building in this neuroregulatory. We really began to then to understand that we can, you know, support people in learning to self-regulate. This is from a study by Dr. Scout Rauch, and he actually did this with Dr. Bessel van der Kolk. They used a PET scan for this particular study. And basically what they were doing is they're asking people who had a history of trauma to read, a number of years after any of their trauma happened, to read their traumatic script, to just write it down and read it. And they were just sitting there, okay, reading this, and they were used a PET scan during this period of time. And what they found is that what they thought they would find, which is the amygdala, which is on your bottom over here, the amygdala started going like this. Okay, it started flaring, started getting very active years after any trauma, just reading it. But their amygdala, which is responsible for fight or flight, is going like this. But one of the things they didn't realize was going to happen, and it's the lower left or right, I guess you're right, the Broca's area of the brain, which is responsible for speech, actually started to atrophy. You know how they talk about speechless terror? You know how sometimes we say to somebody we're serving when they're upset, just talk to me or talk to somebody about it. But basically what they're finding is speech is not available. I think it's interesting that Raul mentioned that also in some of the things he's talking about. So now I want you just to move to a study that's really kind of, I think, puts all this together. And this is a study by Jacques Ponskep, and who also has worked with the National Child Traumatic Stress Network. He actually is a neuroscientist who studies rats at play. That must be fun, right? So he has a big studio, a big laboratory, and he raises rats. And what they do is that the rats are born, then they have a time with their mom because they're mammals and they nurse. And then he puts 2 rats in a cage and they play. And these are the 2 types of ways that rats play. Could I have 4 people come up and model how rats play? Okay. But that is how they play, so that's how they're counting it. So what they find is that they play all the time. How many of you with 2 or 3-year-olds, your child gets up how? Happy, right? And if they get up one morning not happy, what do we know? Something's wrong, right? Because they get up and ready to play. Same thing with rats. Now mind you, these rats have always lived in the laboratory. Their parents, their grandparents, their great-grandparents, generations have lived in laboratories. So what he does is he measures how often they play, then he puts what he calls a minimal fear stimulus. 1 cat hair. 1 cat hair he puts into the cage. What do you think, they've never seen a cat, by the way. Generations have never seen a cat. What do you think happens when he puts the minimal fear stimulus, 1 cat hair into the cage? Anybody? Play stops for 24 hours. 24 hours, no play at all. Then he takes the minimal fear stimulus, the cat hair, out of the cage. What do you think happens to play? They start up again. For the rest of their lives, they never play the same amount pre-cat hair. And what Dr. Glenn Sachs shares is that if we have a helping environment, your offices, your interactions with the people you serve, and you are the person who's supposed to really support this client, this person served, and you in some way provide an interaction or provide an environment that re-traumatizes them, that they're never going to trust you again. You know, I mean, now that's not, he's just theoretical there, okay? But how important it is, like when Raul said, if you're having, you know, pass the baton, what our friend who's Commissioner of Delaware says to all of the providers, just like this, as a provider, just like this, all the community providers, and what she shared as Commissioner of Mental Health and Substance Abuse, she shared, if you're having a bad day, stay home. And if you have a lot of bad days, get another job. Because this work is so important. And trying to support somebody, what happened when you were traumatized? You lost control, right? There wasn't trust there, it was a loss of control. You are the bridge. You are the bridge back to healing. So every interaction, every time, every day counts. So we're going to skip this. This gets to the fourth core concept of development. Guess what? Once again, it has nothing to do with whether or not you were grounded. It has everything to do with somebody cared about you. It's all about human relationships. So I'm going to ask you to humor me here. So I'd like everybody, is this one on too? Okay, I'd like everybody to just kind of model what I do. Okay, so if you could put your right hand up in the air, put your finger and your thumb together and start waving it around like this, okay? Everybody's waving it around. Now I do exactly what I do. I want everybody to put your fingers on your chin. Okay, how many people put it on their chin and how many people did what I did? Right, okay, because I asked you to. But the reason I did this under human relationships is that it's not just what we say, it's what. If you have trauma, or if you have a mental illness, and if you have substance abuse challenges, you are acutely sensitive of reading body language, right? Acutely. So when we build relationships with people, it's more than what we say. It's really us setting up how are our, you know, what are our, what's our body language like? What in fact are we doing? So in fact, it gets to that place. How many of you have ever heard, and I'm going to raise both hands on this for me, somebody saying, about a client, look at Sharon, she's up to her old tricks again. You know, there's you know, Jose, boy, is he manipulative. Of course, we would be too if you had that. We all would be if we had that. Rather than us saying, and this is what's important in terms of creating a trauma-informed care environment, what might I not be doing that is causing him to feel dysregulated? What could I do differently to support him feeling calmer around me or in our office or in the environment, you know, that wherever you're working with him or her? And in fact, this has gotten to the place that in Massachusetts what happened, and I know that you all have community programs and aren't doing restraint, but a nurse in a hospital ended up being part of restraint with somebody, and after the restraint, she said to the person, I am so sorry. It's my job to support you in learning to self-regulate, and we obviously have not done that. I am so sorry. What happens when you apologize to somebody? You know, that what you broke between you actually begins to heal. And Massachusetts actually has now made that a requirement in hospitals and residential programs, that if anybody's ever restrained or secluded, you actually have to apologize. And it's not saying this was, you know, I'm sorry that you threw it through the window. I'm sorry we could not help you at this point. What can we do differently? So that leads to the fifth developmental concept. This kind of gets back to this whole focus on recovery. The nurses in the room again. If you have a 4-year-old in the hospital for cancer treatment, and you let that 4-year-old regulate their own pain medication, are they going to give themselves more or less than the nurse? More. Less. 4-year-olds know better than a trained medical professional. One of the reasons you were able to be a successful adult is at some point somebody allowed you to make decisions about your life. Okay? You had choice. And so one of the things about trauma-informed care environments is choice, 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 choice. Really, really engaging people in that choice. So, and then what we're finding is actually the course of development can be altered. When you truly create environments that are trauma-informed, that offer choice, where the physical, actually environment is one that is really trauma-sensitive and soothing and healing colors and sensory items around and dogs and peers. Speaking of which, we have peer advocates in the room, right? Who are the peer advocates? Raise your, stand up if you feel good about standing up. Could you stand up? Look at this. Yes. Okay. Peer advocates. We love you. Recovery Innovations in Arizona has some of the best outcomes. Just Google them. Recovery Innovations in Arizona. I hear you have a living room project too here. You know, they do amazing work. 62% of their staff are peers. 62%, and they believe that their outcomes towards recovery are because they've moved in that direction, you know, to really support. So really, we can. What we're finding, this isn't just about learning about trauma, we can actually make a difference. Kind of like the poor woman in Arizona, the congressperson who was shot. What's happening? She's recovering slowly, okay? She knew one word, now she knows, what, 3,000 words or something. We can support people. So there's lots of things that we've listed that work. Yes, sir, sorry.
Where did you say that was at, the 62%?
That is what's actually, Recovery Innovations. They started in Arizona, but now they're actually across the world. They have programs throughout. There's some, I don't know all the states they're in. I know they're in North Carolina. I know there are a lot of programs are using their model in Australia. Yeah, so they've moved from, you know, from 1 or 2 peer advocates to 62% of their staff. And, you know, they're trying to, they were at 50%, they're trying to get up to 75.
Thank you.
Yes, yes. So what works? These are just some of the things that work in supporting the people who we are serving and really recovering and being able to have a framework for addressing their trauma issues. And so when we become trauma informed, we truly begin to clear the path towards resiliency and recovery. That's really what happens, is when we're trauma informed, we're in the best place to begin to do that. And when we do that, when we begin to clear that path, the people we serve all begin to feel like, hey, I'm truly important. I'm a cool dude, okay? And if you look at some of the studies in education, what we find out is that when you treat somebody as if they're really smart and capable, guess what happens? They become that way. Other people start treating them that way too. You know, so every single day counts. And so with that, I'm going to actually close my part of the presentation with a quote by one of my favorite people. And this is Dr. Martin Luther King Jr. And what Dr. King shared was, cowardice asked the question, is it safe? Expediency asked the question, is it politic? Vanity asked the question, is it popular? But conscience asked the question, is it right? And there comes a time when one must take a position that is neither safe, nor politic, nor popular, but one must take it because it's right. And I think this is particularly germane for setting up environments that are trauma-informed, for setting up environments where when a fellow staff member actually raises their voice or gets very controlling or irritated with somebody they serve, that we're able to know that it is right to intervene. Public praise, private feedback, that it is right to intervene. It's right to take every step we can to make sure your environment, your staff are truly, truly trauma-informed. And so you all were extraordinarily respectful audience. You were wonderful. Could you, like, once again kind of turn to your neighbor and this time just say, you are really hot. You're hot. You are hot. next presentation from David. And then after his presentation, we're going to have time for questions and wrap up. Somebody actually already slipped me a question, and the question was, Beth, how do you look so young? So I'll tell you that when we do the wrap up. Okay, so now to David.
Does David have got slides? No slides.
Hey, good morning. My name is David Fuller, and I'm from Brooklyn, New York. And just to kind of correct the bio, my last position was at the New York Association of Psychiatric Rehabilitation Services. I was their Forensic Peer Services Coordinator for the state of New York. I left in September due to health reasons. But I'm presently employed back with Health and Hospitals Corporation again as a behavioral health associate, and I do trainings there within the HHC and run some specialized groups on the inpatient psychiatric unit. I'm a person in recovery. I'm a trauma survivor. I am in recovery from addictive disorders, drugs and alcohol. And I'm also in recovery from the criminal justice system. Now, it's funny, 5 or 6 years of doing this, I still get scared. I still get nervous before I talk. And I tell you one of the reasons why. I have to admit, because see, in recovery is about being honest. And I was breezing through the paperwork. I really didn't read the paperwork thoroughly. And I was under the impression that it was going to be a room of 35 people. And not until I got in the car with my brilliant colleagues, Raul and Beth, when they were talking about, well, there were 700 providers being represented. So, of course, as a person in recovery, I had to go into denial very quickly and said, oh, well, that's the organization. 700 people won't be here. And then as we hit the parking lot, and I saw a couple of hundred cars, I said, maybe there might be more than 35 people. So when I got in here and saw the room, I was very impressed, but I was also very nervous because my part in this wonderful team that I belong to is making all of this stuff real. Because for me, it's not about the statistics, it's not about the research, it's about my life. And we talk about flavors of the month, and I tell you, I was first introduced to Human Services in the early 90s, as a staff member. And I understand about flavors of the month and how leadership brings up this and that, this is how we're going to do it, this is better treatment, this is the new thing. But trauma is really, sincerely what it's all about. Just to pertain, to put it to my personal story, right? I first sought help and treatment in 1978, okay? And I knew it wasn't just about drugs. I went for drug treatment. Everybody told me I had a drug problem. When I went to this drug treatment facility, I told them that, yeah, I use drugs, but it's more than a drug problem, And I had a little courage and I got honest. I said, the truth is that when I'm not on drugs, I am preoccupied with my own death. And when I think about dying, it's a very pleasurable, liberating feeling that I have. And it's very hard for me to talk about because when I tried to talk to my mother about it, the person I trust the most out the world, she broke down in tears. She was terrified, and I mean understandably so. So this was only the second person in my life that I had talked about this to. And the reaction was that, well, that's fine. If you want to see a psychiatrist, that's your right, but you can't stay here. You know, if you want to talk to a psychiatrist, you got to go to the state mental health hospital. So you need to make your choice now. And I got introduced to drug treatment because I got arrested on a felony drug sale and possession charge. And if I had denied having the drug problem to go to the mental health facility, my bail would have been revoked and I would have had to go back to jail. I was willing to do that though, and when I asked him what facility, and he told me the state mental health facility, back then it was during a time called Willowbrook in New York, where Geraldo Rivera made his career. It was horrendous. People sleeping on the concrete, in their feces and urine, people not being fed, people being beaten, abused. So this was my picture of the state mental hospital. So when I thought about that, I said, well, maybe I'll try this drug treatment. So, right? And I tell you, I went through the drug treatment, you know, it was over a year. I did very well. I graduated. Soon as soon as the case was resolved, I came back home to New York City, and I picked up within 10 days of coming home. Okay? I graduated 3 long-term drug treatment facilities through my career of self-destruction. And through those 3 long, hard times in drug treatment, I was never allowed to talk about this depression. I was never really allowed to talk about the continuous pain. People told me that if I was drug-free and doing what I needed to do, that I would feel good about myself. But I didn't. And every time I brought up that I didn't feel good about myself, I was blamed for I wasn't doing something right. I wasn't doing something that I needed to do within the program. I kept getting told it'll get better, but it wasn't. So let me jump back. I'm the youngest of 4 siblings. All, you know, I have 2 sisters and I have a brother. All of them have postgraduate degrees. My parents were married 56 years before the first one passed away. I grew up in a 2-parent household. I never missed a meal. There was no violence or drug or alcohol use in my home. I never heard my father even raise his voice to my mother. I had a couple of spankings in my lifetime, but believe me, when my father got me, I knew exactly why he was whooping my butt, and I tell you, I deserved every knot. So I wasn't abused in my home, okay? I was taught love, I was taught forgiveness and tolerance. You know, I grew up during the 60s, so these topics came up a lot. You know, my family is from the rural South. You know, I was born in New York, but my parents were born in rural Georgia. Most of my family was in rural Georgia, Alabama, and Florida. And that's where my trauma started, through the racial violence of the 60s. When I was around 5 years old, my father took me on a trip to see my family. It was just me and him. And we were driving down. And it started with small things. When we were driving on this trip, okay, we left at night. So about time I woke up, we were coming through North Carolina. And I wanted to stop and have breakfast. You know, as all little boys, I was a little eating machine. Every little minute I wanted to eat. And I had a taste for grits and biscuits and sausage. And I knew the restaurants down south sold that stuff. In New York, you really didn't see that in restaurants, you know. So I begged him to pull over to this diner that was off the highway. And I was too young to pick up on his reluctance. But I kept pressuring him, and I guess as some fathers do, they want to satisfy their son, and he pulled over, and we went to this diner. And we walked in the diner, and I do remember distinctly how literally it was like out of a movie, like everybody turned around and looked at us. And I really wasn't aware of that black-white thing exactly, you know. And I ran in the diner, and I plopped my little butt in the booth, and there were knives, and the knife and fork was on the table, and I literally picked them up and sat them like that, and I said, "I want breakfast," So my father was walking slow through the diner, and he sat down, and we're waiting to eat, and I knew it was taking a long time for the waiter to come serve us, but I said, "Oh, what the heck." So I had to get up and go to the bathroom. So when I went up to the bathroom, it seemed like it was 40 feet in the air, but it was just, a doorway. And I looked up, and I could read pretty good, because in the first grade, when I took the citywide examinations, I was reading at 11th grade level when I was in first grade. And I looked up, and I saw these signs, black only, white only. And they had water fountains. And the water fountains had signs, black only and white only. And literally, the black only water fountain was all this broken porcelain thing, no refrigeration, it looked dirty. And 4 feet away, there was a nice, these were new then, the new refrigerated metal water fountains with a nice chrome finish and cool water, because remember, this was hot summertime. So I thrustly, went over to the water fountain, and I started drinking out of the water fountain, and then I went into the black-only bathroom, and when I went in there and saw feces still in the toilet, and at the nasty toilet, I didn't want to go to the bathroom in there, so I left there and I went into the white-only bathroom, and by the time I came out the bathroom, there were 3 or 4 men standing, I guess like where the maitre d' station would be, staring at me. And I just looked at them, and I just walked by them, and I could see the anxiety in my father's face, and I wasn't sure what it was about. And my father asked me, "Why did you do that? Why did you do that?" And I'm like, "Why did I do what?" He said, "Didn't you see the signs?" And I said, "Yeah, but that bathroom was nasty and the water was warm." And he's like, "Sit down, sit down." And after a while, we still hadn't got served. And I said, "Dad, why haven't we got served? Everybody else, those people came in way after us, and they ate and left." And let me tell you, boy, I was a little arrogant little kid. Let me tell you. I said, waiter. Now you remember, I'm 5 years old, right? And the guy's like looking at me. He actually came over, and he had an attitude. And I said, "I would like to order breakfast." And the guy said, "We don't serve your kind." And I looked at my father like, "Are you going to tell this guy something?" And my father didn't say anything. When the guy walked away, he grabbed me by the hand, and he was pulling me out the restaurant. And I was like fighting back. I'm like, no, we're going to eat here. We're going to eat here. And my father's pulling me and pulling me. I was very upset. When he finally got me out of the restaurant, I really realized that, he wasn't going to give in. I was very upset with him. And it was the first time that I lost respect for my father. I felt in my heart that he was a coward, and he was not standing up for me. And it's hard for me to talk about this now, because I realize as a parent that his only concern was protecting me, But at that time, I couldn't see that. And at that time, I was not really taught to verbalize. Well, men weren't to verbalize hurt and fear and pain, you know? And we got in the car and we headed back down the road, and I think we stopped at a Howard Johnson's down the road. And back then, Howard Johnson's was one of the few hotels that would accommodate African Americans. And, you know, we had our breakfast and we went in. This was a very difficult summer for me. Because after that situation, we got settled at my grandmother's house in Fort Gaines, Georgia. We went into town, in a town called Albany, Georgia. It was one of the bigger cities in Georgia back then. And I was with my Uncle James at the time. Uncle James had a beautiful, brand new 65 Fleetwood Cadillac. These cars were huge, you know. It was so big that in the front seat I could stand up and like hold on to the dashboard and like just, you know, like a tour bus for me. And we were driving through town. I remember it was very early again, you know. We used to travel a lot at night, and I found out when I got older why that was. But, you know, we hit town about sunrise, I guess about 5 in the morning. You know, summertime, sun comes up early. And there was a gentleman, young black man, that was hanging from a lamppost. And I was very young, as I've said over and over again, and I didn't really realize what I was looking at. And I asked my Uncle James, I said, why is he hanging there like that? Why is he hanging there like that? My Uncle James didn't answer me. When we got closer, there was an alley, and there was a lot of men. These were men, and they were men who didn't look like me. And there was a young man, I guess of his early 20s, laying on the ground, and he did resemble me. And it seemed like, you know, they were just getting the last little kicks and hits from what I could see and remember as a horrific beating this guy got. And I remember they all looked down at us, and when I looked down at them, I didn't feel fear. I felt anger. I felt rage for the first time in my life. And I asked my, you know, I'm sorry, it was not my Uncle James, it was my father at the time. Like I said, this is difficult. And I begged him to help this young man. I said, Dad, please help him, they're beating him to death. Help him, help him. And once again, my father pulls off, you know. And once again, I felt my father was a coward. And once again, I felt helpless. And for the first time in my life, I didn't feel that my father could protect me. I didn't feel safe. I don't know if people understand how important feeling safe is in growing up. You know, it's essential to your development. And for the first time, and you got to understand, a lot of the stuff I talk about is through hindsight. It's not like I understood this stuff when it was going on. But yeah, I didn't feel safe. And we spent the whole summer in Fort Gaines, and yeah, there was a lot of fun and a lot of playing and a lot of things that were enjoyable, the peach farm and watermelon and grandma's love, you know. But I got one more lesson before going home. There's this little guy named Bobby, white boy. And I mean boy, he was like 7, he was my age. And we used to play all the time at the end of the fence on my grandmother's farm. My grandmother had about 40 acres, so it was easy to get lost. And we used to play every morning, you know, at the end of the fence where there was a hole, and I used to go on his side of the farm, and he used to come on my side. And then, you know, just before we were leaving, it might have been a week before we were leaving, I went to the fence and I called for Bobby, and Bobby came out, and I got ready to run down the fence like we usually do, and he said, "David, I can't play with you." And I said, "Why not?" He said, "Well, you're a nigger, you know, and my father said I can't play with niggers." And you know, it's funny, you know, when he told me that, he told me in a way, there was no like anger from him or animosity or, you know, he was just doing what his parents told him to do. And I could tell he was sad about it. You know, he said, "But you know, my father would get me if we play, and you know, he said we just couldn't do it," and he ran back in the house. And it was only about 80 or 90 feet, you know, from the fence to his house. And when he was running back, it just seemed like the longest 90 feet. You know, I felt so alone and abandoned. And I tell you, you know, that summer of '65 was one of the hardest summers for me. And in a way, it just seemed like it went downhill from there, you know. When I was growing up, I was a very imaginative, happy little boy, you know. I dreamed of going to outer space. I tell you, uninterrupted, I probably would have been truly a science geek, you know, with a pen pad in your pocket and the whole deal. Because I love imagining outer space flight and chemistry. I loved history. I loved learning. Boy, my imagination was explosive. That's the only way I could tell. I used to, you know, get junk out the closet in our house and, you know, just build models of the different things that came to my mind. And I used to draw pictures of what I thought other life forms would look like. You know, just, you know, I think about it now, you know, it's me describing it, but I was beautiful inside. I was really happy and loving, you know, inside. But things changed, you know. I came back up to New York that summer, and that next summer, the summer of '66, I lost 2 uncles in Vietnam. I got a lot of uncles. My father had 15 brothers and 3 sisters, okay? I lost 2 uncles in Vietnam, and there were some circumstances that really affected me. I found out that my Uncle Oscar and my Uncle Bro died in Vietnam. And I'm almost sure it was that same evening that CBS was televising the war in Vietnam. And as some of you are old enough to know, that this was the first time war was ever televised on TV. Excuse me. This particular evening, they had pictures of soldiers that just felt the effects of the napalm bomb. If people don't know what napalm is and what it does, it burns. And it burns at thousands of degrees. And on this news broadcast, I saw the smoldering bodies of American soldiers on TV. I saw soldiers which, you know, literally I was a foot away from the screen. You know how little boys do, I'm up on the screen. And I could see the melting skin on the soldiers. This is before ratings, you know, people were screening on what was televised, you know, and that. And the immediate association I made is, this is how Uncle Bro and how Uncle Oscar died, because they died in Vietnam. So for most or not all of my life, I had this picture of my uncles burning in my mind. That this is how they left. And it was a very tumultuous time to be an African American in the 60s. And I had this view and this anger and this resentment that my uncles went, fought, and died for a country that won't even serve me a hamburger at a counter. That I couldn't get breakfast with my father in that restaurant. It's not right for a man, a boy that young, to be that angry. It's not natural. You know, when I think about it now. I still can't explain in words what it did to my soul. That's the only way I could explain it. And it didn't stop. You know, I grew up in the time of busing in New York City and integrating the schools. And in the second grade, there was some young men that just didn't think I should be going to school in their neighborhood. And I was on a school bus with a bunch of, you know, my schoolmates, 1st through 4th grade. And all of them weren't black. There was, you know, it was a mixed bus. But they thought it was okay to throw a Molotov cocktail through the window of the bus. And it was funny, I was sitting in the 3rd seat on the right side at the back of the bus. And I remember looking out the crowd and they were yelling, you know, this, you know, all kinds of names I shouldn't repeat and language I shouldn't repeat. And the anger in their faces, and I remember saying in my mind, like, what did I do to them? Why do they hate me so much? You know, I don't even know them. And the Molotov cocktail came through the window, it burst, and a couple of my friends caught on fire. And, you know, I'm glad to say that none of them died, and none of them were horribly disfigured, you know, thank God. But to this day, I still have that picture of my friends on fire. I ran to the back of the bus, hit that emergency back door. I jumped out the bus. I ran. The first corner I hit, about 80 feet away, there was a New York City police car to my left. I saw the car. I did not stop. I kept running straight for 1.5 miles until I hit a street called Hillside Avenue in Queens, New York. And Hillside Avenue was the strip where all the city buses connected, you know, thousands of people down there. And I knew if I could get down there, I would be safe because the older guys would look out for me, you know. So I ran a good 1.5 miles, no exaggeration. I never turned around. I had this idea in my mind, if I turned around and somebody was there, that I would freeze and I wouldn't be able to run no more. So I just ran and I never looked back. I knew what terror was. You know, I felt terrified. And I got down to that bus and I've never been so glad to see that ugly blue and gray city bus to that day. I put my 5-cent in, that's show you how long ago it was, right? I put my 5-cent in and got a ride home. You know, that same bus is $2.50. Right? Yeah. Inflation. Of course, when I got home, later that evening, my parents had heard what happened, and they came up to my room, and they had, you know, they said, David, were you on that bus? And of course I said, no, Mom, I wasn't on that bus. And it was the first time I really remember lying to my parents. I just lied, you know, and I was 38 before I told them the truth, you know. But I lied because I was afraid that my mother, the loving, protective woman she would be, would lock me in the house and never let me go out again. And it sounds ridiculous now, but this is how a little boy thinks, you know. I tell you, I grew up with 13 guys on my block, you know. I mean, they were my best friends. You know, on Saturday mornings sometimes, you would find 6 or 7 of them in my room, or I should say, my loving mother would open my door and find 6 or 7 of them in my room. And she would never get angry. She would never put people out. She closed the door back. Sometimes she would gather clothes, and she would put clothes in the washing machine, and she would fix big breakfasts, you know, hot breakfast. My mother was old-fashioned. I didn't know what cold cereal was. That was a snack. You know, we always had hot breakfast. I didn't know what store-bought bread was until I was like in the 2nd grade. You know, she would bake bread. I mean, she didn't have a full-time job since World War II. And that's how her and my father wanted it. She had a college degree, which actually, for African-American women of her time period, was very exceptional, you know. But she chose to raise and take care of her family, and my father chose to provide the finances for her to do that. So, in hindsight, you know, I imagine my mother pretty knew what was going on with my friends. Most of my friends grew up in households not like mine. There was alcohol, there was abuse in that household. I know at least 2 of my friends had parents that severely abused each other, mostly the men against the women, but I remember Mr. Veal, God bless his soul, used to get beat up by Miss Veal too sometimes. You know, those black cast iron pots or something, boy, you know. And most of these guys had trauma in the household, you know. I think back now, you know, through my training and experience now, I really can make the assumption that at least 3 of these guys, now let me repeat it again, 3 of these guys were sexually abused at home. And that's one of the things I want to bring, you know, to you today. That when we talk about trauma, if we talk about trauma, usually we're talking about women and trauma. When we talk about men, we're usually viewed as perpetrators, you know, of domestic violence, violent street crime. They never think of that things might have happened to us, to hurt us. You know, like Raul was saying, hurt people. Hurt people. And that statement directly connects to my life. And forgive me if I jump back and forth and I get a little scattered, but like I said, you know, this is a personal story, you know. But I remember growing up, when I was going through those hard times in school and being attacked at school, let me tell you, it didn't end there, because I used to take that bus back to my neighborhood in St. Albans in South Jamaica, Queens, and I used to have to do the fight all over again. Because now I had to fight the black guys in my neighborhood, because they felt I thought I was trying to be better than, because I wasn't going to school with them. So I used to have to fight in the afternoon with the white guys about coming to their neighborhood to go to school. And then when I got home, I had to fight the black guys that I lived with because they thought I was trying to be bougie, going to school with all white people. So all I did was fight, fight, fight. And let me tell you, I lost most of these fights. I got my butt whooped all the time, right? Because I was raised that you love each other, you know, literally turn the other cheek, that you should forgive people who transgress against you. And I tell you, you know, in hindsight, these were beautiful values, but that crap was not working for me. I got tired of getting my butt whooped, and that hurt, you know? In hindsight, though, I wish I had kept letting it happen, because I tell you, around the age, and I know I left my friends, I'll get back to my friends. Around the age of 11 to 12, I forget exactly how old I was, though. There was a couple of guys who were picking on me. They wanted to take I guess literally my lunch money, you know, your mother give you $1 to go to the store, which back then was a lot of money. You could buy a lot of candy and soda for $1. And they wanted my $1, and I didn't want to give it to them. And my friend Raymond was on the same block. He was just walking, I don't know, about 50 feet or so behind me. And these guys came up on me, and I looked to them for help, you know. And Raymond said, just fight, just fight. I ain't helping you this time. You just do what you gotta do, and some. And he always told me, you know, if you're outnumbered, pick up something, do anything, you know. But I was always afraid of hurting somebody, even though I was getting my butt kicked all the time. I don't know what happened this day. I guess I got sick of being hurt, and there was a small pipe laying on the ground. And these guys came in on me, and one of them kicked me in my side, and I fell over against the wall. And when I slid down, I picked up that pipe. I shut my eyes and I swung that pipe, and I felt that pipe hit something. And it hit one of them in the head. And they fell to the ground. And the other guy looked like he got ready to run. And instead of me running away from him, I ran after him. And I hit him across his back 3 or 4 times. And they both was on the ground. And for the first time, I felt safe. And you know, there's a lot of guilt and shame connected to this story, because even though I felt safe, I felt ashamed of what I did. Even though it protected me, I felt guilt and shame. I felt guilt and shame in the 2nd grade when I ran out of that bus, because I left my friends there to burn. And I felt like a coward, and I felt guilty because we were friends. I should have helped them. And even though in many groups and many third positions, I was told it wasn't my fault, that is not how I felt, you know. Especially knowing how many times I had been jumped and abused by groups of people, and all I ever wanted was someone to help me. And then when my friends were in trouble, I wasn't there, I ran, you know. This thing called trauma, you know, guilt and shame, those feelings have a lot to do with it. The guilt and shame, being a victim, you know, how I can identify with my sisters who have been raped and sexually abused, and people can't figure out how these women could feel that it was their fault, and how they blame themselves for what happened, and the shame and guilt of it all. Well, I'm a man, and I can identify, you know. I can relate to how that feels, you know. And the reason I share that is because in trauma, yeah, recovering from trauma could be different for genders between men and women, but you know what? The feelings are the same. Hurt people, hurt people. I learned a horrible lesson that day, that if you hurt people before they hurt you, you might not get hurt yourself. I'm talking physically, you know? I was not prepared, though, for the guilt and the shame that would eventually eat most of my soul away through my life behind these actions. Because, yes, there was a period of my life that I was violent. That through fear ruled my life. And there was a rule that you do it to them before they do it to you, you know? I went through high school. I was still trying to be that son my mother and father wanted me to be, you know. I was an athlete. I played football, track, wrestled, state champion in 2 of those sports. I was actually being looked at by the Olympic Committee in 1977 for the 220. I had the 30th fastest time in the country, and I was only 14 years old at the time. 15. 75, I'm sorry. So I still had opportunities, you know? I still had this home that was safe, that people encouraged and supported me in doing good things, but I was still keeping the secrets, you know? The first time I saw a person shot, I was 11 years old, you know? Sometimes people are just too young to go through what they go through, you know? To know the smell of blood and gunpowder when you're 11 years old is something that really changed my life. You know, to watch the light leave out a person's eyes due to violence was something I didn't talk about until I was almost 40 years old. You know, drugs came into my life when I was around 17. And I tell you, you know, it's funny, this morning, the last couple of months, I've been, you know, as I said, I've been going through, you know, some health problems. I had E. coli twice in 1 month, you know, and it created some other stuff. So, you know, my kidney and my bladder's being monitored, and, you know, I'm fatigued all the time, and, you know, there's pain sometimes, and, you know, I have a lot of people that care about me, so I find myself talking about it and talking about it and talking about it, right? And it's easy to fall into self-pity, you know? It's easy for me to say, why do I have to be sick now? You know? Why me? Why me? But you know what? It is easy for me to forget how blessed I am. I used drugs and alcohol for 20 years, okay? Heroin and cocaine was my choice. I used to like to smoke the coke and sniff the dope, and the reason I liked it, because for the first time, since maybe I was 5 or 6 years old, I kind of felt that I was normal, like other people. Because there was a period of my life, before drugs and alcohol, that I didn't experience pain. I mean, I didn't experience pleasure, or laughter, or happiness like other people. I would laugh at jokes, because I didn't want people to confront me about why I wasn't laughing. You know, what was wrong, because if I didn't laugh, you know, they said, David, what's wrong? You know, you okay, blah, blah, blah. I got sick of that question, so I would just fake the laughter, but frankly, David didn't find nothing funny. I didn't know at that time I was dealing with major depression. Because in the African American community, we didn't talk about mental illness. We didn't talk about psychiatric disability. The treatment center said, I just had a drug problem and I needed to say no. But I tell you, you know, when I think about the things that have happened in my life, I am blessed. I was doing some numbers. Now, you know, I want to complain about the little sickness I might have now. But do you know, I did some math, and this is a conservative estimate. Do you know, in my 20-year career of self-destruction, that I easily have used 32.5 pounds of cocaine? I mean, just think about it, sitting on that table to my right. 32.5 pounds of cocaine. 16 pounds of heroin. All right? Not grams, not ounces. 16 pounds of heroin, just sitting on that table, right? 7,300 packs of cigarettes. 7,300 packs of cigarettes. 1,040 gallons of alcohol. I got a cold and I complain. Right? It's a miracle. People who are in recovery are living miracles. And that's why I come and I reveal some of the strongest pains and disappointments and guilt and shames of my life. Because the thing that helped me get better was hope. It wasn't therapy, it wasn't counseling, it wasn't medication. It was somebody who said, I've been through what you went through, and I got better. And I believed them. They were authentic. You know, when I put these numbers out, you know, I didn't even put all the other little straggling things I used to cope with my trauma. My medication, because that's what it was all about. Drugs and alcohol maybe were about pleasure, maybe the first 3 months or so. The rest of that time was purely self-medication. I really didn't use to get high. I wanted to feel like you guys. Or maybe I'm making a big assumption. Like some of you guys. Right? I just wanted to be normal and laugh at Joe and watch football and, you know, be able to just sit on a park bench and watch the birds and not have overwhelming anxiety for no apparent reason. I got tired of looking behind me and not being able to sit with my back to the door and just all the other idiosyncrasies. I've experienced a lot of violence to myself through this lifestyle. Like I said, my medication cost me $200 to $300 a day. And pretty much for the 20 years, I had to do things that would be able for me to afford my medication. I sold drugs, and I would steal. Shoplifting mostly. I kept a few little rules, like, you know, I wasn't into the mugging thing. You know, I just couldn't see myself mugging people who were just trying to work and pay a bill like me. But yes, I would shoplift and I would steal. And it wasn't because I was inherently a dishonest person. I was just desperate. And without my medication, life was more than I could tolerate. I mean, suicide was always an option. And I did try 3 times, you know? And I survived truly through divine intervention, and I'm not preaching to anybody, I do believe in God, you know, and I believe in God because my life has proven to me that there is a power greater than myself that exists. I don't put that on anybody else, but that's just for my life. I carry the scars for these suicide attempts every day. Every day I take a shower, I just look at the scars that I put on myself. I look at the holes from the 3 times I've been shot. I look at the gouges and slices of the 4 times I've been stabbed in a life-threatening way. I have to clarify that because I have been cut in skirmishes and shuffles and other kinds of fights, but 4 times in a life-threatening way. You know, where the blade broke off in my skull. And I had a staph infection going to my brain, and my head was so swollen that I could look to the right and see my head. Where they wanted to give me my last rites, they were asking me, did I have family? And I told them no, which was a horrible lie. I was purely content to dying by myself. The thought of that made me very happy. Actually, I had so much swelling in here that it closed off an artery that sends blood to my brain, and I passed out. And this was in the hospital. And during that time, I was unconscious. I was at peace. I felt free of pain and suffering. And I will tell you, I never felt happier in my life until that moment. And when I woke up to bright lights and the noises and the machines going and the doctor, the little Korean doctor that was sitting on my chest, who had cut my face back open and realized they had left a piece of the blade in my skull. And when they took that out, and I remember how angry I was that this man saved my life. And of course I was on suicide watch. I had a guard by my door, blah, blah, blah. And yes, when I got out of the hospital, I went back to drugs and alcohol. Because this is not a rational thing we're talking about, ladies and gentlemen. We're not talking about things that make sense. And if you want to make sense of this, you're going to be eternally frustrated. You're going to burn out doing this work because it's not about being rational. All rational thinking has left the building. We are talking about feelings ruling your life, and you just want to feel differently. And whatever it takes to feel differently, you're going to do. I went through these times of being kidnapped and held hostage for 4 days and tortured through this time. I was being held because my godbrother felt that I wasn't worth as much as the drugs he could take from these people. And if it wasn't for an uncle who, was living in that lifestyle, who him and a couple of his associates didn't come get me by force, I probably wouldn't be standing here talking to you now. But I tell you, trauma affects you. It's funny. When they took me, I was put in the trunk of my own car and taken to wherever I was taken. To this day, I really don't know where that was exactly. But it's funny how things affect you. All through my life, this was 25 years ago when that happened. But it's funny, all through my life, I bought SUVs or pickup trucks. And it wasn't until about 5 or 6 years ago that I realized why. Every time I went to open the trunk of a car, I would get overwhelmed with anxiety. Because every time I opened the trunk, I thought about how the world turned black, and then I woke up in the trunk, and everything that happened to me after that, being chained, butt naked in the basement, and being beaten and stuck, and just the fear over 4 days of not knowing when it was going to happen because it's pitch black in there, and just the horrible anxiety of not knowing when things are going to happen. I think that was worse than the things that actually happened, just not knowing when it was going to happen. And I realized that I was working on myself, that my recovery was improving because this May I bought a car with a trunk. And it really wasn't a conscious thing. It really wasn't. I bought a little Hyundai Sonata Turbo. It's a cute little car. A lot better on gas than SUVs, I'll tell you that. But it was a subconscious thing, and I realized that after I signed the papers that this was the first time in 20 years that I owned a car with a trunk. I have driven cars with trunks. I usually try to get other people to go in the trunk, like when we go grocery shopping, and I used to give my wife the keys to open the trunk. And it was 5 years before she asked me, why are you putting the keys up the trunk? I I said, because I don't like opening the trunk. And then we had that conversation. You know, by the way, my wife is in recovery too. Today I'm a father. I got 6 kids. Right? The youngest is 2. The oldest will be turning 25. Right? Yeah, I was 50 and decided to have a baby. But I found out why you should be 20 when you have a baby. I have 4 grandchildren. You know, the oldest is 4, the youngest is 9 months, 2 girls and twin boys. Life is good today. You know, I'm a certified psychiatric rehabilitation practitioner. I'm also a certified substance abuse counselor. I'm also a certified mental health case manager by the Hunter School of Social Work. I've been a guest lecturer at New York University, Columbia University, Hofstra University, Adelphi University, and a couple others that I've got. I've been afforded the opportunity to testify before the U.S. Senate on mental illness and incarceration. And I got to have a sit down with, you know, Senator Patrick Leahy, and we talked about some things. And I think I was influential in getting money increased for the Second Chance Act, where a lot of other stuff was getting cut back, you know, which was more money for reentry programs for people to reenter society in a healthy way. I was talking to one of your CEOs this morning, and I will tell you, you know, this organization is really on track of doing the right thing for people. And I mean, this is a superficial assessment. I'm just going by what I heard, so because I'm sure there's some people out there that say, oh, you don't really know. But there's 5 things people want in recovery, and this is one of the few things I'll make a blanket statement about. There's 5 things people want in recovery. They want a home, they want a job, they want transportation, they want friends, and they want a date. / significant other, somebody to share their life with. You know, I didn't hear nothing about medication, therapy, groups, interventions, case management. I didn't hear none of that. Now, don't get me wrong. Medication helps for some, not everybody. Therapy helps. At least learning how to talk about how you feel and what you go through so you can get your needs met. And that's especially for us men, you know, who a lot of us don't have a clue how to connect a word to a feeling. You know, it's lust or rage or nothing at all, you know. Work, to have a role in the community. I mean, what happens in social things? You know, you come into a room, and what do people say? Hey, what's your name? What do you do? Right? Yes or no?
Yes.
So what happens to the person who doesn't have an answer for what they do? Oh, my name is David, and I'm in the transitional residence. What the hell is a transitional residence? Yeah. People need a job, right? Or a respected role in the community. From janitor to CEO, it doesn't matter, a role. People need a safe place to recover. Some kind of home, you know? It's hard to recover in jail, it's hard to recover. Yeah, because I've been homeless and I've been incarcerated. I think about 9 years of my life have been behind bars. I've slept on the street. And I had family, but I had too much shame, too much guilt to reach out to them for help. You know? I tell you, you know, my mother died in 2006. And one of the blessed gifts I got is that my mother got to die and see me happy. She told me, my mother beat 3 heart attacks and breast cancer twice. And she told me after her first heart attack, you know, because I was at her bedside crying, and she said, honey, don't worry about it. I'm not going nowhere until you get yourself together. And, you know, you think, you know, yeah, well, whatever, you don't know what you're talking about. But she did know what she was talking about. Because she did, and I mean, 3 heart attacks and breast cancer twice, and all of this stuff happened after the age of 70. She was not a young woman. And I mean, she was not laid in the bed with tubes in her arm and frail. This woman took care of herself to the end. Lived on her own to the end. Had a great quality of life. And I truly believe her prayers was the spiritual strength that saved her. Because I did nothing to save her. Everything I did was to self-destruct. But through her gift of spiritual energy that got my life in the right order, I've been able to help thousands of people like myself find what recovery is and have a chance to experience a life free of violence, free of coercion, to rebuild families. You know, as in my children, 4 of my girls at a point had entered the foster care system, but now they're not. I have one daughter who's getting an academic scholarship to Columbia University. I have another one who's carrying 100.5 average in her senior year of high school. I got another one that's a great hairstylist. That's what she loves to do. I have a son, my 21-year-old son, who's been a victim of trauma. He was shot in 2009, right after talking to his grandmother in front of his own building with an AK-47. Lost a kidney. His cousin standing right next to him died. And this is what I want to talk about, violence in the community, especially in the African American community. I'm doing a film. They're doing a film, semi, about my life, and it's really geared to violence among young African American men in our community. And the many scopes of trauma, because when we talk about trauma, you know, we talk about the sexual abuse, physical abuse, emotional abuse, but we don't talk about historical trauma, where generations of people have been traumatized, incarcerated, where the grandfather's been shot, the father's been shot, now the son's been shot. You know, how the pain gets transferred to whole communities, not just individuals. You know, when you talk about social economic violence, educational violence, when we talk about our veterans coming home, let's speak about the vets, right? 80% or nearly 80% of the vets that are diagnosed with PTSD had childhood trauma before they even went into the service. And I don't have the data, but I truly believe that's the difference between the soldier coming home who can seem like they can kind of get it together and reintegrate back in the community versus the soldier who has some challenges reintegrating the community. That childhood experience. So what I want to say to you is that recovery is possible. One of the things that I used in my recovery was cognitive behavioral therapy. I truly preach that. Because what I needed to know was how to change the way I perceive reality, because that's what trauma does. Trauma warps the way we perceive reality. And all the groups and medications and talk therapy in the world was not going to help me until someone taught me how to change the way I think. Everybody was telling me to feel better, but nobody told me how. Talk about it. I'm sick of talking about it. What can I do about it? And I think cognitive behavioral therapy was a really good tool because it told me how my past experience affected the way I perceive reality today, and that there were ways I could choose to change the way I think. Not a magic cure, it took time, but now I can identify when my triggers are messing with me. I can identify when my past beliefs are trying to make me act in a non-goal producing way. And I could change the way I act and do things that are goal producing, you know. I've done many things, you know, the first peer counselor in Bellevue Hospital, one of the oldest mental health institutions in the country. I brought peer counseling to HHC. Now they have over 60 peer counselors working in their system. I was the first one to bring trauma and recovery groups to their milieu. I was the first one to work in their forensic peer services, their forensic services division. And we actually had over a year of no restraint, no seclusion in a maximum security forensic hospital. Yeah, right? Hope is the key. Peer services is a foundation of this hope. I just really want to encourage you guys to embrace peer services and recovery. My colleagues have given you a lot of great data. And you know, we could work on getting people to just do that, just smile and have a good life. Thank you, and have a good day.
Going to call on Vanna to do question and answers with you. So we're opening this up to questions and answers.
Questions? Here.
There are many, many organizational assessment tools related to how trauma sensitive or trauma recovery effective an organization is. Do you have some preferences?
NASHFIT has actually a tool, Trauma-Informed Systems, and we can email it to whoever the coordinator of this conference is. It's one I think that's much simpler than some of the other ones, because it's really a set of questions that you can take in a, by kind of like area, or do the whole thing. So I will make sure I email it to your person who organizes this.
In addition, and I agree with Ben, I think there are many assessments out there, and most of them probably work. But the problem is, in a lot of organizations, they use assessment and it becomes all about assessment versus what the assessment is going to do. So the issue that Ben is talking about is when you take a very long assessment, it becomes about the process versus what you're trying to accomplish. So I would encourage you to use a simple assessment.
Thank you.
Are people like giving away money out there or something? Is that what's happening? Any other questions? I know some people are anxious to get moving. Well, maybe what we should do is say Raul and David and I will be available if people don't need the money that's being given away, and we will be answering questions up here if anybody has them. Thank you,
Thank you all. Thank you.